My name is Trudo Lemmens. I'm a professor of health law and policy at the Faculty of Law of the University of Toronto with cross-appointment in the Dalai Lama School of Public Health. I was an expert witness for the government in constitutional cases in Canada related to medical assistance in dying, and I was also a member of the Council of Canadian Academies expert panel on medical assistance in dying. I'm honored to be invited to present here to you some of my views on Canada's path towards expanded medical aid in dying, which already suggests in the title that I see an expansion of the practice in the Canadian context, which to some degree worries me. I will talk briefly about the safeguards, including broad access criteria. I will talk about the rights rhetoric that has developed in the Canadian context and the pressure to expand, resulting in a new bill in 2021, which expanded medical aid in dying outside of the end-of-life context. This will be adopted by Parliament in the coming days, and which also included the reduction of existing safeguards for people who already have access to medical assistance in dying. I will say then something very briefly about socioeconomic factors, inadequate care, and disability supports, which may already raise concerns about some or many of the made requests or the basis for the made requests. With respect to safeguards, something I cannot discuss here in detail, but obviously one of the safeguards is the choice between physician-induced or self-medication in the context of MAID. Self-medication seems to be associated, if you look at the various jurisdictions around the world, with lower uptake, people having more control and with less concerns about the difficult doctor-patient relation impacting on potential decision to have made. Canada has embraced physician-induced MAID, but also allows self-medication. The large majority of cases involve physicians. Access criteria are, in my view, also essential safeguards because they determine the breadth and the extent to which people will have access to medical assistance in dying outside of the end-of-life context. So whether they will have access to medical assistance in dying if they still have years or decades of life left. It's also important for accountability reasons, for potential holding accountable of physicians who may transgress the rules, that there are some objective basis for determining who has access to MAID. In the Canadian context, you see here, and I put simply forward the bold criteria, which are the objective criteria, that there has to be some or clear irreversible decline in capability, and that natural death has to be reasonable foreseeable, at least under the current law as we have it in Canada. These are already quite broad criteria and can be interpreted quite extensively, have been interpreted quite extensively. The notion of suffering in the Canadian context has been perceived from an entirely subjective perspective, which is not necessarily the case in, for example, Belgium and the Netherlands. With respect to more standard safeguards, we see the request has to be in writing. There have to be 2 witnesses, which will be reduced to 1 in the new bill that is coming out. We have an assessment by 2 physician and nurse practitioners of the criteria, of the satisfaction of the criteria. And there is also a 10-day reflection period and the need for reconfirmation of consent, which will again be abolished under the new bill in 2021. The regulations on data gathering require broad gathering of data, not fine-grained. They do not give us sufficient information, certainly not as much detailed information as, for example, in the Netherlands. Then there is also limited monitoring, which I will not be able to discuss in detail, but which has been criticized for its shortcomings. What we've seen in the Canadian context is that a certain rhetoric has developed. I think particularly because we've seen here in the Canadian context that it's a Supreme Court decision that declared that there had to be some right to physician-assisted dying in the Canadian context. It didn't say the extent to which that had to be implemented or the extent to which medical assistance in dying had to be provided, in my honest, humble opinion. But the pressure to expand MAID outside of the end-of-life context has then come from lobbying, media reporting, even health professional organizations embracing this kind of rights rhetoric and stating that, well, there is a constitutional right to MAID without fine-grained argument as to how far that right should go and what the balance of competing constitutional rights should be. So it has become a question of right to have a dignified dead, and dignified dead that is seen as being provided by maid. This culminated in the Duchamp decision, a lower court decision in Quebec in 2019, which was a challenge by two plaintiffs who were excluded from access to medical assistance in dying because their death was, in the Quebec context, not seen to be reasonably foreseeable. So they were not close enough to their death. They would have had access at one point, but they had not access when they really wanted it, when they wanted to be reassured to be able to have made. Interestingly, the government declined to appeal the decision in a complex political context. It decided simply to introduce a new bill to expand access and to give in to this lower court decision, which basically declared the reasonable foreseeable death criterion unconstitutional, or at least a restriction to people whose death is reasonably foreseeable unconstitutional. The new bill, which has been voted by the House of Commons and is now before the Senate, introduces a two-track system. It keeps people whose death is reasonably foreseeable under the current conditions as a basis for access to MAID, but it reduces the safeguard for the people whose death is reasonably foreseeable, as I already mentioned. The most important change is that there is a second track for people who are not approaching their natural death. In practice, when you look at the definition, what that means is that basically disabled persons will be singled out for fast-track access to MAID. They and only they will fit the criteria of track 2, and they will actually quite easily fulfill the criteria of track 2 and be able to ask for MAID. There are some additional procedures that are introduced under track 2. A 90-day assessment period, which can be shortened, will focus on, for example, have adequate social supports, healthcare supports, financial supports been a basis for this MAID request, and can these be addressed sufficiently? There is also a requirement that there has to be one assessor with expertise in the medical condition that causes the suffering. It does not have to be a specialist. There has to be some form of expertise. So it's a limited additional safeguard. There are also additional informed consent measures. The strongest one is that the physician has to agree that the patient seriously considered other options. Interestingly, and this is internationally unprecedented, there is no obligation under Canadian law, neither under the current bill, neither under the new bill, that people who may have years or decades of life left first have to have exhausted all of other options. In other words, in Canadian law, patients with years or decades of life left can now decide under the new bill that they do not want to have a standard therapy, and physicians, or at least the medical system, would be under an obligation to provide access to medical assistance in dying. There is also a very serious controversy around the fact that the government, or in the bill, already committed to making mental illness as a basis for MAID available in 2 years. So in 2 years, people with mental illness will have access to medical assistance in dying. When it comes to the data, I cannot discuss it in detail. I already told you that they are not fine-grained data, but the reports that are coming out from Health Canada, and that give us a broad sense of the basis for a request of medical assistance in dying, in my view, create some concerns. You see here, for example, broad statements about the nature of the suffering as a basis for MAID, with medical factors that can be addressed if adequate support, adequate palliative care is provided. We see that inadequate pain control, or even simply the fear of it, is a basis for MAID. We see socioeconomic factors, burden, the sense of being a burden on others, and loneliness playing a role. But we see also broad concepts, such as the loss of dignity or the loss of bodily function, which in my view can be associated with the growing discourse in Canada in the wake of the legalization of MAID, that really presents MAID as the only dignified option, and which sends the message to people with disabilities and elderly that life with the loss of bodily function and dependent on others is no longer worth living. When you look at this official data about palliative care and disability supports, the official data suggests that 82% of people have access to palliative care, but there is actually, this is self-reported data in the first place, There's no detailed information about the quality and the form of this form of palliative care. We see, even from the official data, that there are questions about timely, quality palliative care. And if you look at independent studies that have been undertaken, they are conflicting, but some suggest that, for example, 40% have not had previous palliative care involvement. I would also emphasize that there are growing anecdotal reports of people already requesting access to MAID for economic hardship isolation during the pandemic, which is not surprising because Canada's investment in social and healthcare supports is below the OECD average. And so there is concern that economic pressures, absence of good access to healthcare, the fact that we don't have a national pharmacare program may result in people with disabilities and elderly requesting access to MAID. So in conclusion, I said something about the safeguards. I emphasized that there is an expansion outside of the end-of-life context, that there are serious limits to the data, and that social determinants of health and the limits of healthcare